let's talk about schizophrenia. When we think of schizophrenia, this is a thought disorder. Now, the previous chapter was on mood disorders. This is a disorder of thought. The way the people think is different and it is considered abnormal. So, when you think of schizophrenia, think of people who hear things like someone is after them, the government is after them, or they have purposeless movements. This type of actions are seen in schizophrenia. DSM-4 used to break down schizophrenia into 5 different types. But when it came to DSM-5, they removed all these types and just called it schizophrenia. But it is important to know that there is a difference in the presentation. In a question, they will never ask you what type of schizophrenia it is. They will just ask for the diagnosis and the answer will be schizophrenia. So just to know how patients present, we'll go through the different types of schizophrenia. Again, this is no longer seen in DSM-5, so you will not be asked questions about it. We have the first type, schizophrenia, which is of disorganized type. These patients, they are disorganized. They hear voices, they talk, act, behave in a very disorganized manner. Let's take a look at this. This patient complains that over the past 8 months, he has been increasingly withdrawn, does not socialize, or show any interest in his job. He typically spends his time at home, inside his room, and his wife hears him saying the police is looking for him and everyone is working for them. On questioning, a flattened affect. This is a hallmark feature of schizophrenia. He also admits to auditory hallucinations. We have different types of symptoms, and this is schizophrenia disorganized type. Next, we have schizophrenia catatonic type. This is a psychomotor syndrome. In the sense, these patients, so let me write this. So these patients either move a lot or do not move at all. There's a very famous example. Think of the Tasmanian devil. So usually, if they move a lot, they will have purposeless movement like the Tasmanian devil has. And if they do not move at all, they will be staying in one place literally the entire day for hours on end. They will be staying in one location without any type of movement. They will just stand or sit in one place in one position. So let's take a look at this patient. The patient over the past 8 months has shown a dramatic increase in his activity, walking several times around the house with no purpose, mimicking her movements, followed by episodes of sudden immobility. She also complains that he rarely speaks with anyone, and when he does, it is usually a repetition of what she says. This is what you see in catatonic type. A 25-year-old man is brought to the primary care physician by his wife. The wife complains that over the past 8 months, he has been increasingly spending their savings on lottery tickets, claiming he's going to win big. Now, we see the psychosis symptoms here. When asked by his wife to stop, he becomes agitated and has once threatened to attack her. His wife says that he has been previously diagnosed as a type A personality. We will talk about this in personality disorders. This is the most common type of schizophrenia. These people have grandiose delusions or persecutory delusions. This is schizophrenia paranoid type. And Next, we have a 56-year-old homeless man who's taken to the hospital after finding him freezing in the cold. The physician notes that his thoughts are illogical. He appears to have poor grooming. Poor grooming is a typical sign of schizophrenia, emotional blunting, and loose association. Now, these are symptoms that are left over, the negative symptoms. And this is what you see in residual type. Especially if you get a clue that there is poor grooming, think of schizophrenia. There is one more type, undifferentiated. That type does not fit a single of these criteria. It will be a mixed type. So we classify that under undifferentiated. Now, as I said, schizophrenia is a disorder of thought. That is the way the person thinks. It's not about mood, it's about the way the person thinks. The way the person perceives things, the behavior, and the ability to interpret reality changes. And this is associated with increased dopamine. This is very important when it comes to the treatment. And serotonin imbalance. Now, let's take a look at acute schizophrenia. There are two types of symptoms, the positive symptoms and the negative symptoms. We'll talk about positive symptoms and negative symptoms in a while, but in acute schizophrenia, they have more psychotic symptoms, where they have, let's go take a look at this, hallucinations. These are auditory hallucinations most of the time, where they would hear things. They would hear someone speaking to them, voices, and then there's delusions of grandeur, persecution, then disordered thought processes, bizarre behavior, and this is associated with dopamine. Then there's another type of symptoms called negative symptoms. This is when there is social withdrawal, flat affect, anhedonia, they do not feel any pleasure, reduced motivation, social withdrawal, avolition, and it is associated with muscarinic receptors. We'll take a look at these. In acute schizophrenia, you get the more crazy symptoms. They hear things, they have grandiose delusions, all of these. And you get auditory hallucinations. Negative symptoms are less common. And acute schizophrenia, when it comes to the diagnosis, we will talk about this. It's important to determine the time period. We'll talk about this shortly. In chronic schizophrenia, there's more negative symptoms. The person is more likely to stay at home, do nothing, but they have abnormal behavior because their thought process is different. It might embarrass other people. So these patients think they're fine. Okay, I don't have a problem, but I have to lift my dress up to show the world what I have, or something like that. It's their thought process which is affected. They have poor self-care and hygiene. And some patients may collect things, and it's basically they will start hoarding, and they would shout at strangers or obscenities in public. And DSM-5 requires at least 6 months to classify a person as schizophrenic. We will go through that. Now, we don't usually do CT or MRIs, but if we do a MRI of these patients, a CT of these patients, you will see enlarged ventricles. The ventricles will appear enlarged. Also, if you do a PET scan, in which we basically send a dye, and if the brain area is more active, there would be more colors present. Red colors, all of these. So if this was a normal patient, a schizophrenic patient will have poor frontal and prefrontal cortex activity. And these two lobes are mainly involved in behavior, the way you think, the way you function, and etc. DSM-5 classifies psychotic disorders based on the following criteria. If the patient has less than a month of symptoms, it is considered as a brief psychotic disorder. If the patient has symptoms greater than a month but less than 6 months, it's classified as schizophreniform disorder. And greater than 6 months, the patient is classified as schizophrenia. Now, it's important to note, regardless of the time period, you need to start the treatment. If the patient gets better within 1 month, then we say it's a brief psychotic disorder. But if it goes on till, let's say, 5 months, the patient will be classified as schizophreniform. And if there's no resolving of symptoms with treatment, even after 6 months, it is considered as schizophrenia. And usually when you get a diagnosis of schizophrenia, it's a lifetime diagnosis. Then there's another type called schizoaffective disorders. This is schizophrenia plus 2 weeks of delusions or hallucinations without mood symptoms. I will not explain this right now, but we have it as we go down. And finally, delusional disorders. This was our first topic. They should have at least one delusion which persists more than 1 month. So delusions of grandeur, persecutory delusions, any of these delusions that we discussed previously. And the most important thing is to differentiate this with the others, they have normal functioning. In other aspects of life, if they are working a job, they do that as normal. Just that they have some sort of a delusion affecting them. Again, let's go through these positive symptoms and negative symptoms again. Positive symptoms, we mainly see hallucinations, delusions of grandeur, persecution, disordered thought processes. The way they think is very different, and bizarre behavior. Anything where they are active is considered as positive symptoms. Anything in which they are not active, such as social withdrawal, flat affect, loss of pleasurable feelings, all of these, reduced motivation, these are considered negative symptoms, and in chronic schizophrenia, these are more prominent. Now, the epidemiology of schizophrenia. The most important thing is the earlier the onset, worse the prognosis. So this basically means if you get the diagnosis of schizophrenia, not the diagnosis, if you get schizophrenia earlier, then you will usually have a worse prognosis than if you get it later on in life. And this is why males have a worse prognosis compared to women, because they will get it earlier and females usually get it later. Also, this is related to low socioeconomic status. So if we consider a rich individual, that person, once they get schizophrenia, they can't function normally. Their thoughts are very different. They will fall into a low socioeconomic status. And those who are in the low socioeconomic status will not be able to go to a higher economic status. And there is an increased familial risk. The half of them would attempt suicide. Adolescents who abuse cannabis have increased incidence and worsened prognosis. Again, there's the genetics which is involved here. Early life events such as maternal infections, birth complications, urban births, social factors such as migrating to another country can induce this. If you are an ethnic minority and if there are abnormalities in the brain, these can cause schizophrenia. The symptoms. Auditory hallucinations is when you hear thoughts spoken aloud. Then third person hallucinations, you hear other people discussing you even in the absence of such discussions. Let's say you think you hear your parents discussing about you or your co-workers, even if you are far away, sitting alone doing nothing. Tactile hallucinations, it's the feeling that someone is touching you. Then persecutory delusions, very common in schizophrenia. And thought withdrawals or insertion, they think that someone else is putting thoughts into their head. A common way this presence is, they will say that someone has implanted a chip in my head and now everyone around me can hear. Let's discuss the differential diagnosis. Now, this is what I explained earlier. The differential diagnosis. Mood disorder with psychotic features. It could be under bipolar. We will learn the way to differentiate all of these. Organic causes of psychosis. It could be a neurological or medical cause. We talked about these two. This is the next topic. Substance abuse, such as alcohol, drugs, cocaine, can induce schizophrenic symptoms, and we need to differentiate substance abuse, such as when these patients will have symptoms such as pinpoint pupils. We will talk about cocaine when we come to the chapter on substance abuse. Then mania, manic disorders, encephalitis, psychotic depression, autism, OCD, and paranoid personality disorder. Now let's take a look at how to differentiate all these types. So how does a psychiatrist determine what the disorder is? Let's say the patient comes with major depressive disorder, with psychosis, or bipolar 1 disorder, or even schizoaffective disorder. If we get diseases like this, okay, let's add delusions, delusional disorder. So how would a psychiatrist differentiate these? One easy way is they would draw a small chart like this: depression, and on the other side, psychosis. And if a patient says that he has a depressed mood, has no energy, feels helpless, feels guilty about things, doesn't fall asleep, the psychiatrist would complete it like this. And if the patient says he has auditory hallucinations, this would most likely fit the criteria for major depressive disorder, since the depressive episodes are more prominent with the psychotic disorders. It depends on the situation. Then if we have to diagnose a patient with bipolar versus schizophrenia, they will make another chart like this. Let me erase this chart. Bipolar, schizophrenia. So if the person says he has elevated mood, does not fall asleep, has fast speech or pressured speech, increased libido, all these mood symptoms such as racing thoughts, 1, 2, 3, 4, and all of these. And then if they say if there's no schizophrenic symptoms, then the person would be diagnosed as bipolar 1. But if the patient has disheveled appearance, a flat affect, auditory hallucinations, then we have a mood disorder plus schizophrenia. This would be classified as schizoaffective disorder. There are more things to talk about this, but for now, we will go to the next one. If the patient is being diagnosed as schizophrenia, then they will have these symptoms. All this catatonic behavior, disheveled appearance, auditory hallucinations, all of these. And maybe one or two symptoms that could indicate mania or bipolar. Then, if it is a delusional disorder, being compared with schizophrenia, the person should have normal functioning, there should be some sort of a delusion, and if there are no symptoms of schizophrenia, then the person would be classified as delusional. Now that we talked about schizophrenia, schizoaffective disorder, let's take a look at schizoaffective disorder, because all of these words are confusing and it's very easy to be tested on these. Schizoaffective disorder, let's take a look at this case first. A 35-year-old man is brought to the hospital after the neighbors called the police to report that he was shouting and playing his guitar non-stop. So this is elevated mood or elevated activity. I will write the mood disorders as mood, and the schizophrenic episodes as schizophrenic. So this is a mood disorder. He says his mood is terrific. He hears voices telling him he's going to be the best musician in the world. This is an auditory hallucination. It could be either for mood or schizophrenia. In the hospital, he made inappropriate advances towards female attendants. This increased libido, this is also mood. The patient has a history of psychiatric hospitalization several times since the age of 24. Okay, there is a diagnosis pearl. Like when you get a case, one of the common things that you would see is they had a history of psychiatric hospitalizations starting from a young age, usually 3-4 years, for mood and psychotic symptoms. And also, the way you diagnose these patients as schizoaffective is there should be mood disorders and hospitalizations usually. In between hospitalizations, the person will have schizophrenic symptoms such as hearing voices, commenting on his appearance, and persecutory delusions without any mood symptoms. So when he's having these schizophrenic symptoms, there shouldn't be any mood symptoms. Let's take a look at these. The person has a history of mood symptoms: elevated mood, decreased need for sleep, hypersexuality, and grandiose delusions. And a history of delusions and hallucinations in the absence of major mood disorder. What does this mean? So, in the beginning, when he's hospitalized, he has mood disorders and he also has a brief psychotic dysfunction where he has auditory hallucination. But outside the hospital, he has schizophrenic symptoms. This is key to diagnose schizoaffective disorder. Psychotic symptoms without mood symptoms. If we are to consider bipolar and schizoaffective disorder, the mood symptoms and the psychotic symptoms must happen at the same episode. They should happen at 2 different times. That is important in diagnosing. Let's take a look at these dopaminergic pathways related to schizophrenia and treatment. Now, the problem in schizophrenia is increased dopamine. This is the primary problem. There are 4 dopaminergic pathways in our brain. There's the mesocortical, the mesolimbic, the tuberoinfundibular, and the nigrostriatal pathway. This pathway is involved in inhibiting the secretion of prolactin. When there is dopamine released, it inhibits prolactin secretion. Nigrostriatal pathway we learn this in Parkinson's disorder, regulates coordination of voluntary movements. So what happens if we inhibit these pathways? There is a loss of inhibition for release of prolactin. There's going to be prolactin released. There can be galactorrhea, gynecomastia, nigrostriatal pathway. Regulates coordination of voluntary movements. And if you block that, it will lead to Parkinson-like symptoms. These are called extrapyramidal symptoms. We will talk about this. Now that we have taken the unrelated pathways out, let's take a look at the related pathways. Our main goal is to regulate the mesolimbic and the mesocortical pathways, mainly the mesolimbic. The positive psychotic symptoms are thought to be caused by increased dopamine in this pathway, and this is what we try to inhibit with antipsychotics. Let's take a look at these extrapyramidal symptoms that you get due to the blockage of the nigrostriatal pathways. There is acute dystonia. These are muscular spasms of the neck, eye, tongue or jaw, and occurs right after the initiation of therapy. The moment you start therapy, it will be seen. These symptoms will be seen. There will be muscular patterns. Then Parkinsonism. The symptoms of Parkinson's disease: tremors, rigidity, cogwheel rigidity, bradykinesia, akinesia, masked faces. This is seen in Parkinson's disease. Then akathisia. These people are found to be pacing. They can't stay still for long periods of time. And it can be treated with propranolol. And finally, the most serious symptom is tardive dyskinesia. This is involuntary irregular muscular movements, usually in the face. That means usually the tongue. These patients will suddenly stick out their tongue. These are involuntary and occurs within 6 months of starting therapy. So it doesn't start the moment you start therapy, such as acute dystonia, but within 6 months, these symptoms will start. And this is not something that we can stop. There's no pharmacological treatment that can be stopped, that can be used to stop these symptoms, and it could be irreversible. If there is violence in schizophrenia, you can, if the patient is hospitalized, you can give them haloperidol, intramuscular haloperidol. And you can give them diazepines. And if the patient is less aggressive, you can start off with an antipsychotic, but the problem is this takes time. Antipsychotics take time to begin working. It takes weeks actually. Electroconvulsive therapy can be done. We will discuss these in treatment. The main goal of treatment for schizophrenia is to block the dopamine receptors. And there are 2 types of antipsychotics. In this part, I will talk about the important points, mostly the side effects, and I will talk about the drugs individually in the treatment part. So there are 2 generations. The first generations, the old ones, the ones with more side effects, such as haloperidol, clopramazine. Then there are the newer generation ones, such as risperidone, olanzapine, clozapine. These are considered first line because they have fewer side effects. What are the side effects of these? First generation antipsychotics have a lot of extrapyramidal symptoms, especially the high efficacy ones. We'll talk about this later. Second generation antipsychotics, they have metabolic syndrome, weight gain, and to a certain degree, some extrapyramidal symptoms. And some important points on these atypical antipsychotics include olanzapine and clozapine are associated with weight gain, with the most weight gain and metabolic side effects. Cyparisodone and these drugs have the lowest risk of metabolic side effects and weight gain. Risperidone can cause hyperprolactinemia. There will be increased prolactin release. And this is very important. Clozapine is used to treat resistant schizophrenia. But there is a risk of agranulocytosis if the blood cell levels fall under certain amount, if it is less than 3000 or the neutrophil count is less than 1500, you need to stop treatment. Next, let's take a look at the predictors for good prognosis. Paranoid or catatonic type of schizophrenia is grounds for good prognosis. These are very commonly tested if there are any true or false questions. This is not for USMLE, but some other exam boards which ask for true or false, this is very commonly tested. And if the syndrome, if schizophrenia is of later onset, it has a better prognosis. And females, because they have later onset, will usually have better prognosis. If it is acute, then most likely it is going to be of better prognosis. And if there are obvious precipitating factors, and if we can remove them, there is good prognosis. Positive symptoms indicate good prognosis. No family history, no abnormal brain structures, and if there are good social support systems, these are good prognosis. Poor prognosis includes younger onset without any precipitating factors, chronic onset, the negative symptoms, poor social history, a family history, and if there is no remission with many relapses, this is grounds for poor prognosis. Let's take a look at this case study. We have a 25-year-old woman who is brought to the hospital due to depressed mood. This is a mood disorder, M. Disorganized behavior. This is a schizophrenic behavior. Hearing voices, could be either. Over the past 3 months, the patient has developed auditory hallucinations and now fears that her family has been replaced by aliens. Is this a mood or thought disturbance? It is obviously a thought disturbance. She is afraid to leave the house, stays in bed most of the day, and is unable to care for herself. The psychiatric history is significant for 2 previous hospitalizations for depressive and psychotic symptoms over the past 5 years. During the first hospitalization, she was suicidal and heard voices. During her most recent hospitalization, she was severely depressed and preoccupied with paranoid delusions and auditory hallucinations. And like I said, if they ever mention the word between hospitalizations in these kind of patient, think schizoaffective. And now they will talk about the symptoms of schizophrenia without mood disturbances. Month-long periods without any mood disturbances, but continues to hear voices. She makes poor eye contact, her mood is depressed, but has no suicidal ideation. She is convinced that her mother is an alien trying to harm her. The patient does not use alcohol or illicit drugs. Which of the following is the most likely diagnosis? Bipolar 1 disorder with psychotic features, delusional disorder, major depressive disorder with psychotic features, schizoaffective disorder, schizophrenia, and schizophreniform disorder. Let's take a look. Bipolar 1 disorder would manifest with mood symptoms and psychotic symptoms at the same time. But there is obviously a separation between the two in between hospitalizations. Delusional disorders. She's under the delusion of persecution, but there are more symptoms which says that this is not just a delusional disorder. Major depressive disorder with psychotic features. Because there are a lot of psychotic features, we cannot go with this. Remember that table? Schizoaffective disorder. This seems to be the most likely answer. Schizophrenia. If there were no mood symptoms, we could go for this. And also the time period should be greater than 6 months. Schizophreniform, 3 months. Okay, it's less than 6 months. And in this case, it's 3 months. The next question, a 33-year-old man comes to the hospital, is brought to the hospital, after being found wandering the streets barefoot and shouting to himself. Although he takes antipsychotic medications, his family is having difficulty managing him at home. The patient believes he is fighting an alien war, and his thoughts are directly controlled by a device that was implanted in his brain during an abduction. So his thought process is affected. Previous attempts to use haloperidol and risperidone resulted in minimal improvements. So he was on antipsychotics, but there was minimal improvement. The patient is alert, restless with poor grooming, disheveled clothing, and has a flat effect. Basically the symptoms of schizophrenia. He refuses to answer most of these questions and accuses his parents of being part of the conspiracy and mumbles nonsensical words. Which of the following would be most effective for this patient's illness? Now, it's obvious that the antipsychotics given are not working. So, what is our go-to if this is not working? Clozapine. This is used to treat resistant schizophrenia. A 24-year-old man is brought to the office by his mother due to a change in behavior over the past year. 9 months ago, the patient abruptly decided to quit his job in his last year and insisted on moving back home to work on my research without being disturbed. Since then, he has stopped going out with friends, seems uninterested in his usual hobbies of playing poker, and spends hours on his computer researching government conspiracies. These are thought disturbances. He stays up at night, sleeps during the day, and showers only once a week. His personal grooming is very poor. The patient has no motivation to look for work, and his mother reports that when she encourages him to go back to work, he becomes agitated and accuses her of being one of the government agents. Physical examination shows poor hygiene, but is otherwise normal. Lab examination is unremarkable. This question must be changed. What is the most likely diagnosis? We need to take a look at this patient's history. So I added these questions recently, and so like I said earlier, I make this document just before the lecture, and I will be adding these questions to my book in the upcoming days. I will be releasing the second edition soon. What is the most likely diagnosis of this patient? Considering the time frame, it has to be schizophrenia. Next, we have a 38-year-old man who's brought to the emergency department by the police after he assaulted a stranger who he thought was following him. On examination, the patient shouts, "You don't understand, the Russians are after my secrets." His thought process is disturbed. In the emergency department, the patient is diaphoretic and tremulous. He is very easily distracted and cannot give a clear history. Blood pressure is elevated, pulse is elevated with normal rhythm. Extraocular movements are intact and the pupils are dilated. His speech is loud, rapid, and difficult to interrupt. Which of the following is the most likely diagnosis? This seems to be cocaine intoxication. The dilated pupils, the increased blood pressure, the sweating, tremulousness, all of these with schizophrenic-like symptoms indicates cocaine intoxication. We will discuss this in substance abuse. A 15-year-old boy is brought to the office due to unusual behavior. The patient's mother reports that his behavior began to change 2 months ago when he started withdrawing from his friends and losing activities in his classes and school activities. During this time, his grades declined, and he spent hours each day developing a code in which certain colors had specific personal meanings. His mother says he insists on wearing the same blue shirt every day. He doesn't even let me wash it anymore. Poor personal hygiene. His mother has heard him talking to himself late at night. The patient does not use alcohol or illicit drugs. Vital signs are normal. On physical examination, the person is wearing the stained blue shirt and jeans. The patient makes minimal eye contact and is slow to respond. But he becomes eager to describe his color system when asked about it. Which of the following additional mental status findings is most likely to be seen in this patient? Let's take a look at this. This person seems to have the diagnosis is most likely schizophrenia. This is the answer. Let's take a look at why the others are not. Euphoric mood is in mood disturbances. Fluctuating levels of consciousness. This is seen in delirium. Olfactory hallucinations are usually associated with seizures. Pressured speech is in mania, which is a mood disturbance. Tactile hallucinations, it's not common. A 25-year-old man comes to the emergency department to report that he is in danger. The patient claims that transmitters inserted into his house and are broadcasting his thoughts to everyone around. Now the government wants to kill him. The mental status examination shows that she appears to talk to someone who's not present. She's hospitalized and olanzapine is prescribed. At the patient's upcoming follow-up visit, which of the following studies must be obtained? So here we have thought disturbances. This is thought broadcasting. And which of the following studies should be obtained? Olanzapine is a atypical or second generation antipsychotic. First generation antipsychotics are associated with extrapyramidal symptoms. Second generation antipsychotics are associated with metabolic symptoms. So the most likely study that must be asked to be done is fasting glucose and lipid profile.